Yeah, no, it's fine. All right, let's go ahead and get started. I'm really, really excited for you guys today. Isn't this exciting? What a crazy week. So I'm thinking about maybe doing a review session. I would say Monday, but none of you are going to study. Maybe Wednesday, because you'll study more and have better questions. Maybe online, maybe in person. We'll figure something out. It might be late at night, like WebEx or something. We'll see. So, I know, how did Clen Med go last? All right, cool, good. So, now you got a little bit of taste of the schedules. What I will tell you is spring is definitely the toughest, challenging as far as content, information, that kind of thing. And I do this on purpose. I front load everything while you guys are still fresh. And in the summer, we back off just a little bit. And in the fall, we back off big time. Because the problem is, well, you end up figuring it out, which is good. So you figure out how to do PA school. But then the next thing you have to fight is the burnout. The burnout gets worse. So that's why I back it off a little in the summer, then really back off in the fall, because the burnout is real. You figure out all the challenging stuff and the hard stuff and the persistence and the knowledge and all that stuff, but the burnout is something I'm still trying to figure out. It's just is what it is. So good. So today, so we talked about the autonomic nervous system, which is really complicated, and there's a lot of mental gymnastics on cholinergic / muscarinic and sympathetic, and that they kind of have opposite things to each other, and then all of those mechanisms, whether it's the G sub S stimulatory protein linked receptor, G sub Q or G sub I, and then the differences on the elevation or decrease of cyclic AMP or the increase or decrease of calcium. We know calcium is the great doer of the body. And so when we talk about allergies today, you'll see a lot of similarities. And pretty much all of our G protein linked receptors or membrane bound receptors in our body follow these protocols as far as calcium or no calcium. Whether it's an action potential or heart muscle contraction or smooth muscle contraction, or even your mast cells degranulating, you'll see that all of the internal pieces of elevating calcium, whatever, are pretty much the same. And allergies are really, really common, and there's different types, kind of diluted down to two major types, the seasonal and perennial, where seasonal tends to be from outdoor allergens like dandelions, and perennial tend to be indoor allergens like dogs and cats and things like that. Dust mites, cockroaches are a really common allergy. But allergic rhinitis is the result of our immune system recognizing foreign material, and it's not necessarily harmful to us, but our immune system thinks that it is. And it's mainly the result of mast cell degranulation or basophil degranulation. Usually by our adaptive immune system and our B cells making IgE antibodies that trigger this release. Well, there's that. There we go. And this usually this leads to a release of histamine by our mast cells, leading to that inflammatory cascade that we saw before. And if this is happening in your nose, then it causes allergic rhinitis. If it's happening in the bronchioles of your lungs, it'll lead to an asthma type of situation. If it's happening on your skin, it'll lead to contact dermatitis. But all the mechanisms are generally the same. And one specific thing about asthma, because we'll talk about that more in the respiratory system, you'll see that, well, anytime inflammation is going on within your respiratory tract or your nose, your lungs, your throat, or whatever, you're going to have a couple of things in common. You're going to have the stimulation of secretions, so your body's trying to push it out by stimulating secretions that you cough up or you blow out your nose or whatever. Same thing happens in the lungs. And you get the vasodilation we've seen before, and all those things I taught you in immunology. So a lot of times when people are blowing their nose, they're like, oh, my nose is so clogged, I got so many boogers and stuff up there. And that's not the case, actually. What happens is you get the vasodilation and your turbinates swell up. So no matter how much blowing you do, it's not the result of bunches of boogers and stuff. It's your turbinates just physically swollen. Now, there will be secretions, but that's why when you blow your nose, it really doesn't help much. And it's the same thing with asthma and things like that too. And then we'll talk a little bit about itching, because that's a common thing with allergies too, and sneezing, or if it's on the skin, or itchy watery eyes with allergies and things like that, like allergic conjunctivitis. And when talking about the treatment for allergies, the first thing we need to think about is histamine, because that's our major mediator with allergies. So it's probably going to make sense that when we use drugs, they're probably going to be histamine blockers, mainly histamine receptor blockers, so that histamine can't have its effect. You might think, oh, antihistamines are going to be the major thing, but that's only one component in the treatment of allergies. There's many other things that we can use as well to treat them. We have nasal corticosteroids. We have mast cell stabilizers. We have sympathetic drugs, because we know parasympathetic makes secretions, right? So sympathetic is going to be anti-secretions. We have anticholinergics, which are sympathetic-like, right? The anti of parasympathetic equals sympathetic, kind of. It's the way you can think about it. We have anti-leukotrienes, which will be more common, and we'll talk about it in much more depth in the respiratory asthma lectures. And although we'll briefly kind of look at these today, the major role of this lecture, again, is just to focus more on the antihistaminergic medications for allergy, because the major contributor of allergies is that release of histamine, which is synthesized by L-histidine decarboxylase from L-histidine into good old-fashioned histamine, which is an imidazole ring with an amine group on the side, and it makes some CO2 in the same way. And similarly to kind of how epinephrine, we saw epinephrine was made by decarboxylation. Histamine is formed by the decarboxylation of histidine as well. Interestingly, you don't care about this, but I like it. Histamine and epinephrine are both amines with a 1+ charge and are decarboxylated, and they both have ring structures and look kind of similar. Anyway. And although mast cells secrete histamine from allergens, they also degranulate histamine from infection or mosquito bites and are the first part of that inflammatory cascade that we talked about in physiology. And so for mast cells, it's a normal function that they do. But basophils are another thing. Mast cells, okay, I'll give them a pass on making histamine because that's what they do, but basophils, they're just bored. These cells have very high concentrations as well. And they're also complexed with other things like vasoactive peptides, like heparin, leukotrienes, and other things. And basophils, because we're not fighting weird things that we used to fight throughout all of humanity, they just get bored and they decide to become an allergy-related cell. We learned that mast cells generally like to live in the skin, GI mucosa, the lungs, and they become important in asthma and the production of our secretions. My mom's calling me. Hold on. She never calls me. Hello?
What are you doing?
I'm lecturing.
Oh.
Yeah, I'll call you back. Love you, Mom. So our mast cells generally live in the skin, GI mucosa, and things like that. Histamine, we also know, is found in the enterochromaffin-like cells, or in the gastric mucosa, when you learned about the GI tract, because they're used as neurotransmitters and attached to histamine type 2 receptors for gastric acid secretion. One thing I want you to note now, and I'll say it a couple of times, is that histamine 1 receptors and histamine 2 receptors are very, very different than each other. So if we use an antihistamine 1 receptor blocker, it has no effect on histamine 2 receptors, and vice versa, okay? And I just wanted to bring this slide back from the past because we looked at mast cells when we were talking about the immunology section, right? These were slides 27 through 35 in the immunology lecture. And we saw that our mast cells, whether it's from infection or whatever, like to secrete some things. But I want to kind of look a little bit closer at the mechanisms that cause this histamine release. And so how does a mast cell activate? And this is our mast cell here. And you can see that when exposed to an allergen like pet dander or whatever, the body can recognize it as a foreign substance and make usually IgE antibodies to the antigen through our B cells or our clonal cells. And this is the reason allergies can develop over time, because it takes your adaptive immune system to become sensitized or recognize it. So, usually it isn't the first time you're exposed to an allergen, maybe not the second time or third time or 100th time, but maybe the 101st time, which is why some people get poison ivy and they never have it, and then they finally start getting it, and things like that. And so the IgE antibodies will bind to the antigen, which will also bind to the Fc receptor, which we've seen before, which is an antibody receptor involved in antigen recognition and part of the signaling pathway for tyrosine residues, like tyrosine kinases, like the Janus kinases and things like that. And similar to how we saw in the last two lectures, these tyrosine kinases are going to activate phospholipase C. And anytime we see phospholipase C, two things are going to happen. We're going to release an niacol triphosphate, which works on the endoplasmic reticulum, leading to the increased release of calcium. And it's going to liberate phospholipids in the cell membrane to produce diaglycerol and activate protein kinase C, which also is going to help increase levels of calcium, but also promote the release of histamine and other factors. We also see that these Fc receptors can activate calcium channels directly to allow extracellular calcium into the cell. And the whole idea here is no matter what it's doing, the goal is increasing calcium, which is the doer of everything in the body. You can also see that we have muscarinic receptors down here that also exist on mast cells to promote the increase of cytoplasmic calcium. The idea is that elevated calcium is going to force the degranulation of vesicles filled with histamine and other things. Histamine's the major one, but there's also heparins in there. There's eosinophil chemotactic factor, tumor necrosis factor alpha, neutrophil chemotactic factor. And we also see that the elevation of calcium also directly promotes and activates phospholipase 2, which, if you remember when we talked about prostaglandins, phospholipase 2 produces arachidonic acid from your cell membrane. And that arachidonic acid is important for the production of leukotrienes or prostaglandins by cyclooxygenase and things we've seen before. One thing I'll point out here, which isn't as important now, but will become more important in the asthma lecture, is leukotriene C4 and D4 are really important when it comes to asthma or anaphylaxis or body-wide inflammation responses from allergens. They're about 1,000 times more potent to cause smooth muscle contraction in your lungs than histamine is. And they also directly stimulate mucus secretion. So what we find is because leukotrienes are about 1,000 times more potent than histamine, we usually don't use antihistamines for asthma because of that. They're not great at treating asthma symptoms. Anti-leukotrienes are much more effective because of that potency. And you can also see, again, that elevation of calcium will directly result in production of tumor necrosis factor alpha and various interleukins by the mast cell, which we learned in the immunology section. So hopefully some of this is review. It's just more in depth looking at the mast cell directly. But these aren't the only things that can activate mast cells. This slide has a question mark on the receptor because we actually have no idea how this happens. But we know that it can happen. So we know complement, like C3a and our C5a, can trigger mast cell degranulation. Bradykinin, substance P, which is mainly produced, we call it substance pain, because it's produced and it increases our feelings of pain, like prostaglandins do. Various venoms and other things, lots of different things can activate mast cells. Mast cells have a little bit of a temper. They're very easily triggered. Certain drugs can do it too. What we find is, especially opioids, morphine, codeine, tubocurarine, which is a paralytic, vancomycin, which we'll learn next semester, which causes red man syndrome, is a direct result, and we don't know how it does it, of drugs inducing mast cell release, and it makes people really flushed and itchy and red and things like that. So drugs can do it too. Also just direct physical damage to the mast cell. So a good example of this is water loss from the mast cell due to exposure to dry air. So like if you get a scratch or or a mosquito bite or some damage to your skin, your dermis or your subcutaneous tissue or whatever is going to be exposed to air, which will quickly dry out the area, which will also dry out the mast cells and cause physical damage to promote dilation, vasodilation, and inflammation in that area. Direct cold or even sunlight, like UV damage, can cause mast cell release, which is why when you get a sunburn, it really starts to itch. So shrinkage, mainly due to water loss. And this slide kind of shows the opposite, because when it comes to mast cell degranulation, we can't just always have it on. We have to have ways to turn the mast cell off or inhibit it as well to slow it down. And we find that beta agonism, so sympathetic agonism, or even histamine 2 receptors help turn this off, which makes sense, because if you're running from a tiger, you don't want to be itching and worrying about, secretions in your nose and your lungs contracting up. So it makes sense. And when we talked about like the alpha 2 receptors or the M2 receptors, we learned that those were feedback inhibitors, right? When we were talking about the sympathetic parasympathetic system. And it's the same thing. The H2 receptor works as a feedback inhibitor as well. And so you can think of them as that on the mast cell to keep it in check, to slow itself down. And so you'll find that we use things like epinephrine a lot in people going through anaphylaxis, right? EpiPens. And so like we saw with smooth muscle relaxation on the mast cell, beta agonism is bound to a G protein-linked stimulatory protein, which activates adenylate cyclase, increasing the production of cyclic AMP, promoting protein kinase to decrease levels of calcium and decrease degranulation. So similar mechanisms to what we saw before. Just a way to keep it in check. And then just because I wanted to show you the stomach a little bit, this is a gastric cell, because we also have enterochromaffin-like cells, or the paracrine cells, in the stomach. And either activation by acetylcholine on muscarinic or activation from gastrin is G sub Q linked. Activating phospholipase C, again the same thing, iniosol triphosphate, diaglycerol, leading to the elevation of calcium and histamine release, but this is a gastric cell, right? And then also some prostaglandins too. And we'll see why that's more important next semester when we talk about the GI system. But I kind of wanted to give you an introduction to that now. This is everything I just explained. Sorry for everybody typing. And another thing I want you to recognize is histamine itself is actually considered an autocoid, okay, which is different than a hormone. We talked about it when we talked about prostaglandins. Remember, a hormone is something that travels through the blood, like T4 for the thyroid, to have an effect on some system way downstream. An autocoid is produced by the tissue at the site and used at the site. If histamine was a hormone, then we would all be in anaphylaxis all the time, and we don't want that. And even some people have an inability or an impaired ability to metabolize histamine very well. So they're usually very sensitive to histamine headaches, for example. So I kind of went on a deep dive and I saw that red wine, because it's fermented with the grape skin versus white wine, which is fermented without the grape skin. Grape skins have high levels of natural histamine and sulfites in them. So if you also have a sulfa allergy, you'll be even more prone to red wine allergy. But in people with this impaired ability and they drink a bunch of red wine, they'll feel flushed, their ears will feel like really red or they'll feel really hot, and you get a headache. It's almost like you're hungover before you go to bed. White wine doesn't really do this, but if you have that effect, either one of two things. You're sensitive to histamine, or you have a slight sulfa allergy. More you know. Is that all I wanted to say? Yes. All right. But like we talked about in the first exam, histamine cannot have an action, right, unless it has a receptor to attach onto to have an effect. And there's many different types of histamine receptors, with the main one being histamine 1 with allergies. They're located on mast cells and basophils, and they mediate that inflammation. H2 receptors are feedback receptors on mast cells. They're used on the parietal cells that we talked about to promote hydrochloric acid production in the stomach. H3 and H4, we really don't know much about them. Very little is understood about them. Maybe we think they're G sub I linked for feedback inhibition in the brain, but we actually really don't know. So 1 and 2 are definitely the most important. And now that we kind of see these receptors more, once histamine is released by those mast cells, how does it act on the body? And we'll start by talking about the smooth muscle cells. So whether this is smooth muscle cells in, we'll say your bronchioles, okay, like the lungs. And when we get to the bottom line of this very complicated slide, we're basically going to find that histamine can essentially contract all smooth muscle cells in the body except arterioles specifically. And an example, again, would be like contraction occurring in the bronchial lung cells, the GI tract, muscle fibers, and endothelial cells, or post-capillary venules, along with, well, just that's enough, right? It does contraction everywhere except the arterioles in capillaries, okay? And we have a large amount of different receptors that we find on various smooth muscle cells. We saw some before, but today mainly we're going to be focusing on histamine. We'll talk about prostaglandins and leukotrienes in the future. But again, hopefully you can see a pattern forming because histamine 1 activation is G sub Q linked, leading to the activation of phospholipase C, increasing inositol triphosphate, diaglycerol, protein kinase C, increasing calcium influx, both inositol triphosphate and calcium, increases calcium. And the elevated calcium, we know calmodulin can activate myosin light chain kinase, which will phosphorylate myosin light chain, allowing for myosin and actin to communicate with each other, causing contraction. Okay? I'm getting faster through this because it's the same thing over and over and over again. So it makes sense. Histamine will cause bronchial smooth muscle contraction. And I want you to compare this slide here to I have a note here, slide 61 in the Introduction to Autonomics lecture. So if you want to write a 6-1. On the flip side, like when I brought up arterioles, because I said it actually caused vasodilation in arterioles. And where are arterioles located again? Basically every single capillary bed we have in our entire body. We have histamine 2 receptors there. And we'll see that pretty much all histamine 2 receptors have a G sub S linked receptor, activating adenylate cyclase, increasing the production of cyclic AMP. We know elevated cyclic AMP does what? Activates protein kinase A, resulting in decreased levels of cytosolic calcium. That will decrease the myosin light chain kinase's capability of phosphorylating myosin light chain, leading to that relaxation. While we're here, and I wrote in nitric oxide, recognize from the previous lectures that I said that the parasympathetic nervous system does not directly innervate our vascular smooth muscle. Remember, we have those NANC, the Nancy, non-adrenergic, non-cholinergic neurons, which produce nitric oxide. And we know nitric oxide can freely move across lipid bilayers and promote the increase in the production of cyclic GMP from guanylate cyclase. And cyclic GMP and cyclic AMP have the same exact mechanism forward from that. All right. Yes?
Is nitric oxide also an autocoid?
Yes. Yes, absolutely. Nitric oxide is also an autocoid. And we'll learn that more and more, especially in the cardiology section when we start talking about nitrate drugs like nitroglycerin, because nitroglycerin is converted directly into nitric oxide to have effects locally on tissues. But So yeah, good. And what is, when somebody's, if you know anything about cardiology yet, if your parents have nitroglycerin and they're having chest pain, they take it. It causes vasodilation, which takes pressure off the heart. And you can see nitric oxide produces relaxation. And so nitric oxide in general produces dilation everywhere, whereas calcium is the doer everywhere. All right. So we'll take a little bit of a closer look on the effects of histamine on the vascular system too, because it'll relate right back to immunology that we saw last semester. And so on the vascular system, what we'll tend to find is that vasodilation will occur at arterioles, okay, leading to increased blood flow, and we'll see that at the site of wherever the histamine is being released. And it will also increase capillary permeability, and that's usually causing the edema component. One thing that we'll find, because our blood pressure is maintained by our heart rate and the peripheral vascular resistance, is that when you vasodilate everywhere, your blood pressure is going to drop. And so your body's like, hey, that sucks. We need to increase our blood pressure back. The only way it can is either by vasoconstricting or increasing heart rate. And since it can't vasoconstrict because it's being dilated, like an anaphylaxis, then your heart rate will increase to compensate for that. But this is a slide we've seen before, right? From our immunology lecture. It's on slide 30 in the immunology lecture. I put that note in here. And although this slide is the same but different because we're talking about histamine specifically, but I actually brought in slide 30. Here's slide 30 from the immunology lecture we had last semester. And we'll talk more about prostaglandins and leukotrienes, but we're going to focus mainly today on histamine. Hopefully we remember talking that in arterioles, the red side, right, histamine 1 and 2 agonism will promote vasodilation, leading to increased blood flow to the site of inflammation, which makes sense. We want to increase blood flow to wherever inflammation is going on. But remember, if this vasodilation is body-wide, it can cause anaphylaxis. In this case, we're talking about a specific area, like you got a mosquito bite or you have allergic rhinitis. But in postcapillary venules, histamine 1 agonism kind of causes two things. It causes contraction of the endothelial cells, leading to a gap that forms between the cells. And it also causes contraction of the smooth muscle around the postcapillary venule. And why is this important? Because what we want is to force hydrostatic pressure into the area, causing edema. And so if you have a dilated artery and a contracted venule, and then all of the endothelial cells contract, then all of that pressure coming in from the artery side is going to push out into the areas. It's kind of like taking a straw, poking a bunch of holes in it, and then clipping one end, or constricting one end, and then putting a garden hose on the other side. Water's just going to shoot out of all the holes. That's essentially what's happening. It's hydrostatic pressure, which is what we want because that's going to force proteins and white blood cells and all of that into the area of inflammation to take care of the infection or allergen or whatever. And some of you might be thinking, wait a minute, Dr. O said that H1 agonism causes vasoconstriction and H2 agonism causes vasodilation. So why does it show up here that H1 and H2 agonism causes vasodilation in arteries? And that's because it's complicated. And I want you to compare this slide to slide 67 in the Introduction to Autonomics lecture, because it's essentially the exact same slide, okay? In those arterioles, we have different receptors depending on what we're talking about, whether it's the endothelial cells or the vascular smooth muscle cells, okay? Remember, endothelial cells sit right on the bloodstream, and vascular smooth muscle cells surround the blood vessel to dilate or constrict blood flow. And this mechanism is the exact same that you'll see on that slide. When we have H1 agonism that activates a G protein Q-linked receptor following the same pathway as we saw before to increase calcium, except similar to slide 67, that elevation of calcium is going to activate that nitric oxide synthetase, okay, that type 3 nitric oxide synthetase, which is going to produce nitric oxide, which will easily pass through lipid bilayers, activate guanylate cyclase, increase cyclic GMP, which will actually lead to relaxation rather than vasoconstriction. This is only happening in arterioles, by the way, okay? Also, we see our friend prostaglandins coming here again. Arachidonic acid, that increased calcium can produce arachidonic acid and prostacyclin, which can work on prostacyclin receptors. And when we talked about prostacyclin before, we were talking about it in the clotting cascade and things like that, where it can decrease platelet aggregation and cause vasodilation. You don't need to know that right now, but when we get to that part of the semester, we're going to see this slide again. Histamine, if it can make it to the smooth muscle cell, or if there's damage and this endothelial cell gets sloughed off, then histamine can attach to an H2 receptor, and whether it's prostacyclin or H2 or even other things, it's going to follow the same pathway. And that is what? G protein S linked receptor activating adenylate cyclase, increasing cyclic AMP, activating protein kinase A, decreasing calcium. You get the idea, forcing relaxation. So when you get a chance, go back and look at those mechanisms in the Introduction to Autonomic lecture, compare them to this one, and it will start to make a lot more sense because you'll recognize that a lot of these mechanisms are the exact same. Whether we're going to be talking about asthma or allergies or NSAIDs, anything that has to do with the sympathetic or parasympathetic system, they all kind of work on these same protein kinases and cyclic AMPs and all of that. Yeah.
So for histamine to have an effect on H2, it essentially has to bind to H1 first.
Yes. Yes. So, yeah, so histamine will have a tough time getting into this H2 receptor. But the interesting thing is in arterioles, whether the endothelial cell is there or not, so let's say it's still there, it's going to attach to H1 and it's still going to cause relaxation. Now, if the endothelial cell gets sloughed off because there's damage to the site or whatever, then it'll still cause relaxation because the H2 is on the smooth muscle cell. So no matter what, the result in arterioles is dilation. All right, so these are the effects of histamine on the vascular system, which is complicated, I know. What about our other systems? So like nerves. Well, most of our nerve endings also have histamine H1 receptors, which mainly lead to the itching component and the pain that's associated with histamine release, like after a mosquito bite or after you get stung by a bee or whatever. And this leads to a triple response. And I made a, watch this, ready? Look at this. So let's say I injected you with histamine. So what will happen? Well, you'll have a spot that forms, a wheal formation, and then a flare, which I forgot to put that in. Dang it. Okay, well, a triple response, which is a spot, wheal, and flare. So just like you would get a mosquito bite. That was useless. Let's move on. What about in our airways? Well, I don't know why I looked this up, but in airway smooth muscle, different species have different effects to histamine. So histamine tends to cause bronchodilation in sheep and bronchoconstriction in guinea pigs. But in us, normal individuals, we see that it only causes a mild bronchoconstriction. Again, leukotrienes are probably the main source in bronchial smooth muscle because they're 1,000 times more potent for bronchoconstriction, which again is why we don't use a lot of antihistamines in asthma patients, which is kind of nice. But if you give a guinea pig histamine, it will go into a full-blown asthma attack. I don't know why I put this slide. Okay. Again, we know gastric acid secretion is mediated by histamine neurotransmission onto H2 receptors, which works well to increase acid, but also our parietal cells secrete intrinsic factor and increases volume of secretions. What is intrinsic factor for? Absorption of vitamin B12. Yeah, good. Did you know vitamin B12 is also known as extrinsic factor? But again, there's no cross-reactivity between H1 and H2 receptors. And I put some H2 blockers in here because we'll learn in the future that famotidine, ranitidine, things like that are used to treat heartburn, but have a very little effect, if any, on actual allergy. And if you don't know, ranitidine's coming back to the market. It was taken off in 2020 because of NDMA contamination, but it's coming back. Histamine can also have effects on our adrenal glands and the central nervous system. I told you before that epinephrine and histamine kind of look similar, right? And what we'll find in biology is if things have similar structures, they can actually have similar functions in a way. And so there are effects on the adrenal medulla, whatever you call it. H1 receptor agonism on the adrenals can promote the release of epinephrine, leading to an increase in blood pressure, but really only seen in patients with pheochromocytoma where they're more sensitive to that. And we talked a little bit about that, the formation of vanilla mandelic acid and metanephrines. And we also saw that, for example, acetylcholine from preganglionic sympathetic nervous system fibers normally induce the release of norepinephrine and epi, but histamine 1 can actually raise calcium and induce at least a small amount of release. Not hugely important, though. But in the CNS, we have all three, H1, 2, and 3 receptors, as being somewhat important for neurotransmission. And we'll find that the major reason we have histamine in the brain being secreted is to promote wakefulness and attention, one of the major attention and wakefulness components. So it might make sense that if we have drugs that block histamine 1 because we're using them for allergy, a big side effect might be sedation or sleep. If you've ever taken NyQuil or Benadryl and it knocks you out, that's the reason why, because it crosses the blood-brain barrier. But it promotes wakefulness. We'll learn more about the central nervous system stuff in neurology. All right, so now that we have an idea of everything going on, we're going to be using agents that are antihistaminergic at the H1 receptor. And we have different generations. We have our older first-generation antihistamines, our newer second gen, and our even newer third gen, okay? Our first generations are the oldest of them all, and they're a bit of dirty drugs. And when I bring up dirty drugs, I mean they have the effect of treating allergy, but they also hit a lot of other receptors, which lead to the side effects of the drug. Or they easily cross the blood-brain barrier, and so they'll cause sedation. So we have diphenhydramine, which is what my dog Finn is named after, because I'm allergic to dogs. We have dimenhydrinate, doxylamine, phenyramine, chlorpheniramine, brompheniramine, carbinoxamine, cyproheptadine, triprolidine, promethazine, meclizine, and hydroxyzine. The ones in red are the ones that I use the most common, or the ones that you'll see in over-the-counter agents that are most commonly used. The newer second gen usually have less side effects. These are loratadine and cetirizine. So loratadine is like Claritin, cetirizine is like Zyrtec. And then the even newer fexofenadine, which is Allegra, desloratadine, and levocetirizine. And we'll talk about why those are considered third gen, why they might be better. And so let's start with the first generation antihistamines. And they all honestly work really well for allergies, okay? But look at the structure of diphenhydramine when you compare it to histamine. Now, they're going to look similar because they hit the same receptors. But diphenhydramine has an aromatic group, replacing the imidazole of histamine. And this makes diphenhydramine hydrophobic. which means lipophilic, which means it easily crosses lipid bilayers, just like the 4 tight lipid bilayers of your blood-brain barrier. We also have a tertiary nitrogen, which also easily becomes uncharged and crosses lipid bilayers very easily as well. Remember, it was those quaternary ammoniums that can't cross things. This means with regard to pretty much all of our first-gen antihistamines, as compared to the newer gen antihistamines, it isn't the difference in their ability to treat allergies. The newer ones, the older ones, they all treat allergies pretty much at the same efficacy. So the main comparisons we need to make between the first gens and the newer ones is the differences in their side effect profiles, because that's essentially what the differences are between them. Not the allergy parts, it's the side effect parts. And so whether we're talking about hydroxyzine or diphenhydramine or meclizine or whatever, they're all going to cause sedation, okay? Pretty much all of them. Now, they work well for allergies, but some companies are like, oh, they cause sedation. Well, why don't we just market that? We'll market the side effect as a sleep aid. And so a lot of the over-the-counter sleep aids that we see, ZQuil or whatever, is just diphenhydramine or doxylamine loaded up, and they put sleep on it. So they're actually marketing the side effect, not what the drug is initially designed for. And so when you see things like Advil PM, it's basically your NSAID along with diphenhydramine. That's all it is. So they're marketing the actual side effect as the treatment, which is fine. It's off-label, whatever, cool. I've used it. We all have probably, especially when your nose is like super clogged and you just want to sleep. We also see that pretty much all of our first-gen antihistamines, whether it's diphenhydramine or dimenhydrinate or meclizine or hydroxyzine, they all have the ability to block muscarinic receptors too. So they have anticholinergic effects. Now, the best examples are diphenhydramine or promethazine or whatever, but what are some antimuscarinic effects that you would expect? So antimuscarinic means anti-parasympathetic, right? Which means anti-parasympathetic looks like sympathetic-y stuff. We'll have the review next Wednesday, I think. We'll do that. So maybe we'll do that next Wednesday. So sympathetic-y stuff, when you're running from a tiger or whatever, is you're not going to want to pee, you're not going to want to poop, you're not going to want to make a lot of secretions and rest and digest. So you're going to have the dry mouth, dry respiratory passages, your eyes are going to dilate, your heart rate's going to increase, you can become constipated, you might get urinary retention, which is important, like in somebody with benign prostatic hyperplasia where they already have trouble urinating. So anticholinergic side effects, which might not be so good. Now, it's also used for the treatment of the common cold because our first-gen antihistamines decrease secretions, which we know we make a lot of secretions when we're sick. So with regard to the common cold, first generations are marketed more for common cold than our second or third gen for that reason, because of those antimuscarinic effects. We also find that because it's anticholinergic, we talked about scopolamine before, right? In the last lecture, as being an antimuscarinic for the treatment of motion sickness. Remember, you saw the picture of my niece with the ginormous eyeball because she used a scopolamine patch and rubbed her eye? Well, that means that our first generation antihistamines can also be used to treat motion sickness. And I bring these two up right here, dimenhydrinate and meclizine, because those are marketed for that. They're the most commonly used. They're historically the major ones used for motion sickness or vertigo. Now, technically, you could use any of them, right? But in medicine, if it's historically used for that, that's what people tend to reach for first. So if a preceptor came to you and said, this patient has vertigo, what do you want us to start them on? Although promethazine is technically a right answer, or hydroxyzine or diphenhydramine, the preceptor, nobody knows drugs as much as me. The preceptor will say, no, meclizine is the thing, not promethazine, even though technically they would all work. Anyway. Interesting thing about dimenhydrinate, not that it's important for you to remember, which is Dramamine, it's actually just a chlorotheophylline derivative salt of diphenhydramine, which means what? Your body converts it into diphenhydramine. That's the active ingredient. Dimenhydrinate's not the active ingredient. Your body converts it into that. But because it's a chlorotheophylline derivative, the theophylline is in the same family as caffeine. So that's why dimenhydrinate's marketed as a more less sedative effects, because theophylline is in the family of caffeine, so it's mildly stimulative, so less sedation. It still sedates you. Take one, I promise you, it'll knock you out. And then antivert, meclizine, anti-vertigo, right? These agents can also be used as anesthesia. So a lot of times before I get my gallbladder surgery in the next couple weeks, they're probably gonna load me up with diphenhydramine or something similar, because number one, it'll dry out secretions, so it'll protect my airway, hopefully, so that I'm not secreting all this stuff into my airway. But it'll also dry me out, so I'm not sweating, and I'm also not peeing during surgery, and I'm also not pooping during surgery. So it makes sense to use that. But it can also be injected right into the areas and lead to a local anesthetic effect as well. So anytime you get a mosquito bite and you rub diphenhydramine or Benadryl stuff on it, it might feel a little bit better, because it can be used before general anesthesia or locally as well. All right. So when, let's say somebody takes too much diphenhydramine or whatever, well, there can be toxic effects to this, but most of the toxicity has nothing to do with the histamine part of it. It's all the anti-muscarinic components. So if you take a ton of this stuff, it'll act just like atropine or scopolamine or any of the anti-muscarinics we talked about, leading to intense anti-muscarinic side effects, okay? Excitation, hallucinations, ataxia, convulsions, tachycardia, increased blood pressure, all of those things you would expect, because anti-muscarinics are sympathetic-like, okay? All right, let's move on to the next one. So because the first generations have all these side effects we just talked about, we developed newer drugs for allergy, because we have allergies even during the day when we need to go to work and not have anti-muscarinic side effects or sedation. And when you compare the sedative effects of all the different antihistaminergic agents that we see, chlorpheniramine being very sedating or whatever, you can see that our newer gens tend to be pretty much non-sedating, and actually fexofenadine tends to be potentially even a little bit activating in that sense. And we'll talk about why those things are the way that they are. And so unlike those older drugs, the newer generations are going to have more hydrophilic or charged substituents. So fexofenadine is a charged, it has a charged carboxyl group, okay? It's a weak base, which also makes it harder to get into the central nervous system. And these drugs are also all FDA approved for seasonal allergic rhinitis or chronic idiopathic urticaria. Fexofenadine, again, our first drug. And when you're walking through the aisles at Walmart, anytime you see that purple cap in the allergy section, they're all fexofenadine. So you don't have to buy the brand name, okay? Any of the purple bottles sitting beside it are the same drug, just monumentally cheaper. Don't ever buy brand name stuff. It's ridiculous. Anyway, fexofenadine has a half-life of 15 hours, which is nice because you can take it once per day. And again, that carboxylate group on it can form an anion, meaning it does not cross the blood-brain barrier and essentially has no sedative properties associated with it. So it's staying out in the peripheral nervous system, or the peripheral system. But when this drug is taken with other charged, because it's a charged negative ion, right? When it's taken with other charged positive ions, like as we see with antacids or calcium or even grapefruit juice, orange juice, because all of those have citric acids and things in them, it can actually decrease the bioavailability pretty substantially of fexofenadine, essentially rendering the allergy medicine useless, okay? If you take it with erythromycin or ketoconazole, the absorption is actually increased because it's competing for those P-glycoprotein xenobiotic transporters. So those levels of fexofenadine can increase substantially. But ketoconazole and erythromycin are very uncommonly prescribed, so I don't really care about that. But you don't want to take it with charged things, which is why my usual go-to is loratadine, even desloratadine, fine. I think it's ridiculous, but. So, and when you're walking through Walmart, it's the blue top bottles. Anytime you see a blue top bottle, it's loratadine, okay, which is also generic. I like loratadine because it's the safest and easiest with essentially no drug interactions and does not cause any sedation due to that polar chloride ion on it, so it does not cross the blood-brain barrier. Desloratadine, or Clarinex, was the pharmaceutical company's idea of trying to keep a patent on something. Okay, so when the Claritin patent ran out, they created desloratadine and said it was a lot better because the half-life is much longer. It's 27 hours versus loratadine's 8.4 hour. But guess what? Loratadine is not the active ingredient. When you take loratadine, it's converted by your liver by CYP3A4 into desloratadine. So, you know what I mean? That's ridiculous. So whether you take loratadine or desloratadine, you're getting desloratadine. But the thing is the company wanted to keep their patent on something, so they made Clarinex, like the next version. You liked Claritin? Well, wait until you see Clarinex. It's ridiculous. Absolutely ridiculous. But then, you know, before today, you didn't know that. Nobody knows that. People don't know that. And then we have cetirizine, which is the green top bottles. Anytime you see the green top bottles, that's cetirizine. And interestingly enough, cetirizine is a racemic mixture of the left and right hand enantiomers of cetirizine. Have we talked about enantiomers? You guys remember enantiomers from OCHEM? Because of the chirality centers? See this chirality center right here? So this chirality center has the hydrogen facing into the screen, and this chirality has the hydrogen facing out of the screen, which means they're left and right hands of each other. So cetirizine itself is a mixture, a 50-50 split of the left and right-handed enantiomers of cetirizine. Levocetirizine, or Xyzal, is just the left-handed version, okay? And this drug actually has a similar structure to loratadine, but it lacks that tricyclic ring and the nitrogen in the aromatic ring, which makes the drug a little bit less polar. Meaning actually some of it can cross the blood-brain barrier a little bit. And so we find in about 10% of patients, there can be some sedation with cetirizine, but not a lot, okay? And here is another great example of a patent running out and the company creating Xyzal. It's just the left stereoisomer. So you're getting levocetirizine whether you take cetirizine or levocetirizine, okay? Is it better? I don't know. No. It is what it is. I always love that. Pharmaceutical companies. Anyway, so these drugs, the second and third gen, are not necessarily used for the common cold. okay, because they don't have antimuscarinic actions. They only work on histamine 1. They don't cause sedation. So the first gen are used more for that common cold stuff, okay? Do they actually work? Has anybody loaded up on Dayquil, NyQuil for a couple days and felt like it really, really worked? No. I mean, it makes us feel better, like we're doing something about it. You know, it's like Alka-Seltzer when it's bubbling. It's like, oh yeah, there's some chemistry going on. That's gonna help, whatever that is. Whatever that's doing, that's what's gonna happen in here to the viruses. It makes us feel, it's a placebo. It makes us feel better about it, I guess. Oh, let's take a break. Yes. A what inhibitor? That would be similar to giving somebody chemotherapy because they're tired of shaving their head. You know what I mean? Yeah. So it's overkill. That's a bad, yeah. That was on the spot. I'm sorry about that. Yeah.
How come the loratadine is only approved for the seasonal allergic rhinitis, but the desloratadine is approved for multiple things if the loratadine just can be converted to desloratadine?
Because it's what it was studied for. So although they'll all work on everything, you can only approve your drug for what you specifically studied it for. So in the original, they just studied it for that, but it will also work for all the other ones. It would technically be off-label, but acetaminophen is off-label for headaches. So
a company could just come out and be like, loratadine.
yeah, so what they did with desloratadine is they studied it on more things so that they could get more FDA approvals to say that it's better.
Gotcha. So they could do the same with loratadine?
Yeah, they could.
Just come out.
But the thing is the patent's already up on it, so there's no reason to put any more money into research and development of loratadine. It's crazy. Money.
Okay.
Yeah.
For the anti-emesis and nausea drugs, does that just work for motion sickness, or is it like all nausea?
Mainly for motion sickness, not necessarily for all nausea. Yeah. Yeah. So the newer ones would be okay. But even the older ones, it's not that it'll make you dehydrated, it'll just make you feel dehydrated. So like even if you're secreting, you end up swallowing it all anyway most of the time. So you're not technically having any net loss of fluid. And when you take an anti-muscarinic like a Gen 1, You're just not secreting it, so you still hold on to it. So there's really no net loss. You'll just feel dehydrated because your mouth will be dry.
How'd you figure it out? It's not like the number popped up.
There's a lot of amines, different amines.
Sounds like you said something about history.
Does she drink red wine? Ask her.
But she doesn't drink really ever because it gives her like
So it's very high in tyramine, which is a precursor to our monoamines like epinephrine and norepinephrine. Very high in sodium, obviously, but very high in histamine, which causes vasodilation. Yeah. Not necessarily. She might get hives periodically. Doesn't have that.
I was going to tell her about that when I watched it. I was like, wait, I wonder if that would be good for her.
Works great. Works really well. Migraines, when you break migraines down, they're actually very simple. Most people don't think about them right, though. Oh yeah, that's because the dude with the machine that cleans the floors came rolling through and it reeks. It reeks. All right, let's continue on. So, somebody asked a really interesting question. They saw this here? Loratadine is only approved for seasonal allergic rhinitis, but desloratadine is approved for both seasonal allergic rhinitis and perennial and hives. Does that mean loratadine can't treat perennial allergies or hives? No, it does not mean that. Here's what usually happens. Loratadine, you can only say it's approved for this condition if it's actually studied and ran through the FDA and the FDA says, yep, this shows that it works for this. When the pharmaceutical companies are trying to get these new drugs out, they want to beat everybody, so they're only going to study it for one thing to hit the mass amount of people as possible. So they approve it for seasonal allergic rhinitis. Then when the patent runs out, they need to create the Clarinext version. And so they're like, okay, we're going to make this better. So we're also going to study it for perennial allergies and hives so that they can go tell patients on their commercials or providers who don't know any better that, oh, but this is also approved for indoor allergies and hives. Whereas loratadine, Claritin, don't even think about that anymore. But the truth is that they'll all work for all of the things, okay? And that's one thing that we'll find throughout pharmacology. You're going to recognize these little things on how pharmaceutical companies kind of slithered their way through to make things sound better than they are. Yes?
Do we need to know, like?
No.
Okay.
Technically, tricyclic antidepressants, if you've ever heard of amitriptyline or tricyclic antidepressants, they're also dirty drugs that have antihistaminergic properties. So you could technically off-label treat somebody's allergies with antidepressants, okay? You're gonna see a lot of these things. But it's not what amitriptyline was studied for, but you could technically do that, okay? It also is an anti-muscarinic, so you could use antidepressants to treat the common cold. You know what I mean? There's weird stuff like that, yes.
Just making sure all of the medications that we've talked about, those are medications that patients can buy over the counter.
Yes, some of them no. Like Xyzal, levocetirizine is prescription only for I have no idea why. Hydroxyzine is prescription only for I have no idea why. Some pharmaceutical companies, because there's an extra application process to make it over the counter and make sure it's safe enough. Some pharmaceutical companies don't want to go through the trouble. Some want to gatekeep. It's who knows why. And we'll see examples of weird stuff like that too. Like a pharmaceutical company will make a drug. It's actually pretty dangerous, but it's available over the counter. And then another pharmaceutical company makes another drug that's extremely safe, and it does the same thing, but it's prescription only. Omeprazole and pantoprazole are perfect examples of that. Aspirin. It's a very dangerous drug, actually, when you think about it. Clopidogrel or Plavix is not. You know? Swap them. Yes?
If somebody has like a liver disease or cirrhosis and they have like a decrease in the CYP enzymes, would there be a way like to, I guess, approve one versus the other? Since like loratadine has to be converted to desloratadine?
That's a good question. I mean, one thing you'll see here, it says converted by 2 different enzymes. So even if one is down or the other is down or whatever, it'll still convert. And we also have CYP enzymes in other places too, right? Now, the majority of them are in the liver, but you're right. Technically, there could be decreased efficacy of loratadine versus desloratadine. I think in the real world, it doesn't really matter that much. What I tend to find is in patients with liver disease where it's affecting them this much, allergies are the last thing they're worried about. But that's a good question. Technically, yes. You guys are smart, man. All right. So, one thing here. Anytime you are worried about anaphylaxis, because it is histamine mediated, the treatment is not antihistamines. Now, before you go to the hospital or inject your EpiPen, most people crush up a bunch of diphenhydramine and put it under their tongue and swallow it, and it tastes like chemicals. But the treatment for any anaphylaxis is epinephrine, because not only is it going to cause a sympathetic increase in heart rate, and it's going to bronchodilate and all the sympathetic effects we kind of want, increased blood pressure, vasoconstriction, all of that. That is the treatment of choice, epinephrine versus antihistamine. All right, so what are some other drugs for allergic rhinitis? We talked about antihistamines. This is going to be kind of an introduction to the other things we're talking about, because we've seen some of these before, and then other ones we're going to talk about in the future, but I want to group them here just so you know. And the first thing is our steroids again, okay? We've seen some of these already. We have beclomethasone, triamcinolone, fluticasone, budesonide, momentazone. And the choice you have when selecting these agents, again, mostly has to do with their pharmacokinetics rather than their pharmacodynamics or their action on that intranuclear glucocorticoid receptor. Starting with budesonide. And all of these are going to be taken by nasal spray. But what we'll find with each of these nasal sprays is, yeah, you can see some effect, maybe after 12 hours, maybe not. But it has to take about 2 weeks in order to reach an effect that you want. So one thing I find with patients with nasal corticosteroids is they take them, they say they don't work, and then they stop taking them because it's not working. And 99% of the time, if you have allergies, you've probably done this too, you stop before that 2 weeks because you think it's just not working. Remember, steroids have intranuclear receptors, which takes time to synthesize proteins and make things happen, okay? But being a glucocorticoid, we have to worry about glucocorticoid side effects, right? And so we find that with budesonide, when we give it intranasally, the bioavailability we find in the systemic circulation is about 34%. That means 34% of the drug is able to cross the nasal lipid bilayer into your systemic circulation. And what does that mean if you're using this drug long term? It means that patients on budesonide can have the side effects of steroids, all of the different things, skin striae, thinning of the skin, cushion-oid appearance, fat pad, buffalo hump, which are terrible, terrible words. Decreased immune system, all leaky blood vessels, all those things we talked about. And it also interacts with CYP3A4. So in my practice, when it comes to budesonide, I don't usually use this. And you'll see that even budesonide inhalers for asthma, I don't like them as much either because of this reason. So in my practice, I wouldn't choose good old Rhinocort first. I usually choose this one, which is fluticasone or Flonase, which has a bioavailability of less than 2%, which is nice. It has some CYP3A4 interaction, but if the bioavailability is less than 2%, does that really matter? No, because it's not getting into your circulation as much. So this is my usual first choice because it's cheaper, it's safer, it's people all over the place use it, but technically there can still be an effect on your, even less than 2% still more than zero. Most of the time in the real world, though, we don't care about that as much. If you're going to choose one and remember one and whatever, momentazone is the one you want to use, Nasonex. It's probably the best choice because it has essentially no systemic bioavailability. So it's probably the best long-term option, but it's extremely expensive, even the generic versions. So that's why fluticasone is probably the one that's grabbed the most, but we probably should be using this one more than anything. We also, we'll talk a little bit about mast cell stabilizers, yes?
So people can get addicted to nasal sprays. Why?
So we'll talk about that in a few slides. You won't get addicted to steroid nasal sprays. You get addicted to the sympathomimetic nasal sprays, and we'll talk about why that is. So not all drugs that we use are going to be for allergic rhinitis or allergies. There's topical ones too that we can use for usually the relief of itching, especially itchy, watery eyes, okay? And when we talk about eye drops, these are usually a combined mast cell stabilizer and a topical H1 antagonist. And the first one we'll talk about is kind of a sad one, cremolin sodium. It's not used very often at all. You can use it in the eye. You can inhale it in an inhaler. You can use it in a nasal spray. It's the kind of old-fashioned mast cell stabilizer, which means it inhibits mast cell activation, whatever it touches. The problem is it's such a large molecule with a bunch of oxygens on it that it has essentially it can't cross lipid bilayers pretty much at all. And you kind of have to cross a little bit to get to a mast cell. And there's essentially no side effects whatsoever. And here's a big truth thing. Because some of my patients come to me and they're like, oh, I had breast cancer and my oncologist was treating me, but they weren't doing enough. I started following this coach online who said, start taking methylene blue. And when I started taking methylene blue, that cured my cancer. What you'll find with methylene blue is there's some use for it in specific things. The methylene blue didn't cure the cancer. The patient's oncologist and medication regimen radiation did. If a drug has no side effects whatsoever, then it has no real effects either. Does that make sense? If a drug has a true effect, the more you feel it or the more effect it has, the more side effects it's going to have. That's just how it works. So methylene blue has essentially no side effects, so it really doesn't have any real effects either. Cremolin is one of those, but it's FDA approved. It is what it is. Nobody uses it. Don't worry about it. We have Pimuralast, which is also not used very often. It's a topical application for itching. I don't really care about this one, but it's technically a mast cell and eosinophil cell stabilizer. It's not used. Anybody ever use Pimuralast? Me neither. Olopatadine. This one is used all the time. It's an over-the-counter topical antihistamine, but also can stabilize mast cells and eosinophils. Very, very effective for allergic conjunctivitis, itchy, watery eyes. I have some in my office for my itchy, watery eyes, and it is, it's the good stuff, okay? It burns, but it stabilizes those mast cells, and it antihistaminizes my eyes. The next one is ketotifen, which is also a mast cell and H1 antagonist. Again, these are more for these are all over the counter. So if you're ever, I think it's always fun to go through the over-the-counter aisles and look at the inactive or the active ingredients of things to learn. So if you want to do that, go do that. Find ketotifen and things like that. All right, this is where we get into what are the sympathomimetics. And we'll find when it comes to allergies or asthma, sympathomimetics are actually extremely useful in weird ways. So in asthma, we saw beta-2 agonism is very important with bronchodilation. What we find is if you were to just keep using beta-2 agonists, your body's gonna have pharmacodynamic tolerance and tachyphylaxis, where the drug won't work as well, and then it won't work as well, and it'll eventually stop working. And in allergic rhinitis, sympathomimetics act the same way. The two most common kinds of sympathomimetics that we use in allergy or when you have a stuffed nose is phenylephrine and pseudoephedrine. Now, there's also oxymetazoline and nefazoline. Sudafed is the one where you have to show your ID to the pharmacist. Phenylephrine is mainly in a nasal spray, but you'll see it in some over-the-counter pill forms. There is no evidence to suggest that the pill version of phenylephrine actually does anything, and I believe in the next 5 years it'll be taken off the market for that reason. Oxymetazoline is also only a nasal spray, but it has longer action. and Nefazoline is the eye drop version. But they're all doing the same thing. They're all alpha-1 agonists, which we saw alpha-1 receptors are located on our vascular system, and they cause vasoconstriction. So when your turbinates are all inflamed up and vasodilated and you can't breathe, and you use phenylephrine or oxymetazoline nasal spray, it'll bind those alpha-1 receptors, and within 5 minutes, your nose will be so clear, it's like you've never breathed that clear in your whole life. Has anybody used Afrin nasal spray? That's what it is. Oh God, it's so good. I have some in my office. The problem is that same pharmacodynamic tolerance and tachyphylaxis occurs. So if you use that nasal spray for longer than 3 days, you'll have to continue using it, because when you stop it, you're going to get rebound nasal congestion. It's called rhinitis medicamentosa, which is why people get addicted. It's not like a psychological addiction. It's because anytime you've ever had a stuffy nose, you think you've always had a stuffy nose, and where's your life going from here? So you want to keep your nose unstuffed. So if you use it longer than 3 days, you're going to get yes.
Why are they still on the market?
They work really well. They work extremely well. And, when you have a common cold or your nose is stuffed up and you have to go to work and you have to function, using any of these things in the short term is always the best thing to do. But you can become addicted to it. I was addicted to oxymetazoline for like a year at nighttime. I needed it. And then I had to go through the withdrawal of rhinitis medicamentosa at nighttime, and my wife just listened to me because I got to breathe through my mouth and stuff. But those receptors end up downregulating, and it goes back to normal within a week or so. I have a patient of mine who has been using oxymetazoline nasal spray, keeps it in his pocket for 37 years. But why is Sudafed or pseudoephedrine, why do you have to show your ID and get talk to the pharmacist about it? And that's because the chemistry of it, right? So Sudafed nasal spray or pseudoephedrine has a chemical structure that it's extremely similar to methamphetamine, okay? Here's an interesting thing. Methamphetamine is also a racemic molecule. There's a left and right-handed version of methamphetamine. The right-handed version is the good old-fashioned methamphetamine, Breaking Bad meth. The left-handed version is Vicks VaporPen. I'm going to show you some. That's how important enantiomers are, the left and right-handed versions of things. Let's go to Wikipedia real quick. So, here we go. And interestingly, so if you look, so levomethamphetamine, which is the left-handed version of meth, okay, they even spell it differently. See how they took the O out? They turned the PH into an F. They took the P out. So they call it lev-met-amphetamine. And they did that because they didn't want it to sound like methamphetamine. But you'll see, let's see, where does it say? The trade names. Oh yeah, Vicks VaporPen. Vicks, yeah. You know that thing that you... So levomethamphetamine is a very good nasal decongestant. Methamphetamine is a very good recreational drug. But that's the importance of enantiomers of things. Yes?
Is it easy to switch the...
No. It is impossible to switch the chirality center. Which is why you can get it over the counter. It's much easier to convert Sudafed into methamphetamine than it is levomethamphetamine to dextromethamphetamine. You just need lithium liquid, ammonium T-butyl hydroxide, which acts as a protecting group. So you can reduce the intermediate with red phosphorus. and chloride without destroying the intermediate. And then, I mean, it lets off a little phosphine gas, but you can pump that out. Anyway. But yeah, that is actually a really important point about enantiomers of things. So next time you're sniffing Vicks vapor pens, it's methamphetamine. So here's some examples of like the eye drops. So you can see this one has nafazoline and phenyramine. Phenyramine is our Gen 1 antihistamines, but also nafazoline, which is the alpha-1 agonist. Here's your Afrin nasal spray. This one I think is oxymetazoline. Yep. So when you're looking over the counter stuff, it's interesting things. Here's an interesting thing too. So Sudafed was originally pseudoephedrine, right? But the problem is, and you can see that right here, pseudoephedrine. It works really well as a pill. But now you have to give your ID and ask the pharmacist politely and hopefully not get put on a list so you can't fly anymore. So the company came out with Sudafed PE, which is phenylephrine. The boxes look exactly the same, but there is no evidence to suggest in any study whatsoever, I don't know how they got it passed, that phenylephrine tablets do anything for nasal congestion other than increase your blood pressure a little bit. But this is another attempt at a company saying, now people are buying less of our stuff because they have to ask the pharmacist politely. Let's come out with Sudafed PE, which sounds exactly the same. So they'll buy that instead. Because they know the common cold is mostly placebo anyway. We also have some anticholinergics, and this brings us back to ipratropium. Now we have inhaler versions, but there's also ipratropium nasal sprays. Because remember, anticholinergics work really well to decrease secretions, right? And when you're all secrety, it sucks. So ipratropium nasal spray actually works okay to decrease those secretions, but it does nothing with the congestion part of it. And then finally, just as a introduction for anti-leukotrienes, the most common one being montelukast. Leucast means leukotriene antagonist. You won't have to know that for this exam, but Singulair, which is a anti-leukotriene drug used for the treatment of asthma, but it's also approved for allergies because leukotrienes are a component of allergies as well, more so in asthma and lung stuff rather than everything else. But when you use it in combination with an antihistamine, they work synergistically with each other to help reduce allergy symptoms. And you can see, in places where, just H1 blocker was used and places where montelukast was only used, they had similar effects of each other. So you could rationalize that when you use them together, it actually significantly reduces more than just one of the agents alone. Cool.